So for those of you who are new to our events, my name is Ann Merchant, the unprofessional Ann Merchant, and I work for the National Academy of Sciences, a highly professional institution. And I am joined by...
I'm Rick Lovert. I'm the Program Director of the Science and Entertainment Exchange, which is a program of the National Academy of Sciences.
And so we have been doing our weekly events since April 1st, which seems like, I don't know, just yesterday or forever ago, maybe both, or neither one. But we're very glad that you're here with us. We hope you've been with us before and that you are returning. If it's the first time, we hope you'll come back again because we're going to continue to do events through the end of the year. So we always start by doing a little bit of orientation, by at least explaining a bit about the Academy and about the Exchange. And so again, for those of you who do not know, the National Academy of Sciences is a private nonprofit institution in Washington, D.C. We always point out that we were created by Abraham Lincoln in 1863 in order for the country to have sort of the North Star of science for a way to create good policy using science, engineering, and medicine. And we've been doing that for a long time. One of the fun facts about the Academy is that our very first study in 1863, actually it was two, we helped figure out how, when we were transitioning from wooden ships to iron ships in the Navy, we helped the Navy understand how their compasses would work and how we could navigate. We also, and this sort of demonstrates when people listen and sometimes they don't listen, we were asked about weights and measures and currencies, and the Academy recommended that we migrate to the metric system. I can tell you that didn't go so well because we obviously didn't. But we are obviously still very relevant today. For those of you who joined a little early, you saw some of the rotation of the hold slides, and we apologize that there's no hold music. Rick and I were texting and saying, some people were thinking, are we in the right place? There's no audio, but it's just a PowerPoint deck, so there was no audio. But you may have seen that we included a slide that showed the recent statement from two of our presidents, Marcia McNutt, the president of the National Academy of Sciences, and Victor Zhao, the president of the National Academy of Medicine, recently released a statement that expressed their concerns on the politicization of science. And I just wanted to read a couple of lines because the Academy has been extremely busy. And some of the people, Jeff Kahn, for example, has been very involved with a lot of the work that the Academy has been doing on the COVID pandemic. But they had indicated that policymaking must be informed by the best available evidence without it being distorted, concealed, or otherwise deliberately miscommunicated. We find ongoing reports and incidents of the politicization of science, particularly the overriding of evidence and advice from public health officials and derision of government scientists, to be alarming. It undermines the credibility of public health agencies and the public's confidence in them when we need it most. So I think that, obviously the work of this institution is as relevant today as it was when the Navy needed to understand when their compasses would work and when they mightn't. So we're very proud to work for an institution that is so relevant today. So I guess that part of how we try to communicate our messages is through events like this, but through programs like the Science and Entertainment Exchange. And Rick, as you indicated, you are the director of that program, and so I'm going to toss it to you to explain a little bit about it.
And you totally left everyone hanging. It's totally okay to use a compass on a metal ship. We're okay to use our compass.
I know. Where's the punchline? That was for you.
So the Science and Entertainment Exchange, program of the National Academy of Sciences. If you are a writer, director, actor, studio executive, creative person who is creating a piece of media content, a film, television program, video game, you have a question about science, you can call us or email us, and you can call us at 844-NEED-SCI. And oh, look, Sachi put it right in the feed. And we will connect you with someone. We don't really know anything, but we will connect you with someone who does have the answer to your question from the vast resources of the National Academy of Sciences. This is a free program. We've done over 3,200 consults on films like Avengers: Infinity War, Black Panther, Captain Marvel. And if you are a STEM professional and you're just tuning in and you hadn't heard about this program before, we're always looking for volunteers, and we would love to hear from you. We'd be very interested to hop on a Zoom or a call and get to know you a little bit so that we can connect you with storytellers. Let's see. So I want to special thanks today to Jeff Kahn at the Berman Institute, because without his big brain, we would never have thought to do this event. So thank you, Jeff, for helping us put this together today. I want to thank Ameche, our AV person at the NAS, who is responsible for making sure this all goes smoothly. Thank you, Ameche. Also, the whole office in DC, Courtney Sloan, Jeff Fishman, and Sachi Gerben. Yes, you are hearing the credits before the event, so there you go. And I'd also like to thank our sponsors, Howard Hughes Medical Institute, who supports events like these specifically. They're the reason that we can do this today. Alfred P. Sloan Foundation, Walt Disney Company, Film Nation, Google, the Lyda Hill Foundation, Corteva, and many individual donors like yourselves. There were many of you who gave today, and we really appreciate it. Especially thank you to everyone who joined at the supporter level. We will be sending you one of these as a thank you, and you will also get some special access to Q&A sessions where we're on screen, and then also hopefully we're going to be able to do some events for you that are just for you later in the year. So thank you for that. Little bit quick point of order, just to let you know about the event structure. Down here, down under my finger down there is a Q&A tab. At any point, you can ask a question. In fact, somebody came on right at the beginning and asked a question. And I will be conveying those and curating them and sending them off to our moderator, Lainey. And she has not nearly enough time to answer all the questions. We're going to go as quickly as we can. We're going to get through as many of your questions as humanly possible. If we do not get to your question, it's my fault. Please blame me, not Lainey. And we will do our best to get to as many as humanly possible. So please ask a question, and I'll be throwing them over to the moderator. Now, I think that's all I got for right now. Back to you, Anne.
Yeah, well, we've made a habit. We have sort of, I guess we're calling it our little rabbit hole, that we talk a little bit about some of the things that we've been looking at and finding interesting during the week. And so there are a couple of things. I did not know that there is a state park in Arizona that is called the Crater of Diamonds State Park. And you're allowed to go. They have 37 acres set aside, and you're allowed to hand sift for diamonds. You can't bring in any kind of technical equipment. And there was a young man, he's been going there for years, since he was a child. He found a 9-carat brown diamond. And he's allowed to name the diamond. And I believe he called it like his name is Kevin Kennard, and he called it the Kennard Family Diamond. And it's estimated to be worth more than $1 million. He gets to keep it. I mean, that's kind of crazy. He wasn't even going to turn it in. He was sort of like, I don't know, I think it's a piece of glass. It's so big, it can't possibly be a diamond. I mean, I thought that was crazy. So I thought, how nice for him. David Attenborough is now on Instagram. In 5 hours, he had more than 1 million followers. And how sweet for David Attenborough, because I think it's his first foray into social media. I also, it is Banned Book Week. And so that's kind of a weird thing. I looked at the banned books. They're almost all about human sexuality, and they're all like young adult books. So apparently that's what we freak out about in this country, is that telling young people about human sexuality. So that's what we're banning these days. Oh, and some Harry Potter books. It's insane. And then I read, did you know there was such a thing as competitive gardening? There is, and his name is Medwin Williams. He's Welsh, and he has grown a 3-foot-long turnip, and he has these titanic leeks, they're described. And I'm telling you, there are onions that are this big, and it's not just one, it's like dozens of them. It's insane. So I know, competitive gardening.
Do they have to taste good, or is it just for size?
That's a really good question. I don't know, but they look amazing, and they're beautiful. I mean, they look otherworldly, so it's worth looking at. And then, because Rick makes fun of my canned goods, this is a jarred good, but this is Dark Horse fermented Dijon probiotic mustard with wildflower honey and smoked onions. I mean, come on. People joke that I don't like condiments. I do not like pedestrian condiments, but this looks awesome. So there you go. And Rick, I think you have some rabbit hole items for us too.
Yeah, I got to admit, I made a pandemic purchase, you guys. I bought this guitar and immediately put it on the operating table. So for those of you who are interested in what the inside of an electric guitar looks like, it looks like that. And I'm happy to tell you more about that offline if you're interested.
Are you
So,
going to show it to us once it has survived surgery?
oh yeah, sure. Hold on, it's right here.
Oh, say, he was just
Look at
waiting.
this. You can't even tell. You wouldn't even know. I ripped it out. Yeah.
And that is ice blue. It looks white, but it is ice blue. He has shown it to me in situations where I can tell the color. So
That's right.
there you go. That's our rabbit hole. We hope that that you find some joy in competitive gardening at some point. So now on to our event, and we are very grateful to Jeff. I think he gets the award this season for being the most frequent guest on our virtual stage. But not only that, he brought us the entire Hopkins team, and I think that was another great service that he did us. Oftentimes we're grateful that he just brings himself, but he brought us this whole group, which was a real bonus. And because when we started talking about everybody clicking furiously on this dashboard and not really knowing how it came about, where did this thing come from, who's maintaining it, where is all this data funneling in from, and the first thing he said is, well, you need to talk to Lainey. That's really who you need to bring into this conversation. And Lainey is one of these obviously highly accomplished people that if I think I had to read your CV, because I think you've got a JD, a master's in public health, a PhD, I'm not sure what else you have, but all I know is that you clearly were the right person to talk to about this. And in our first conversation, you immediately knew because you had a roadshow ready to go so that you would know who we should talk to about this dashboard. So we feel very, very fortunate to have sort of brought this band together so that our audience can get kind of under the hood, behind the scenes, and understand a little bit about really the service that Hopkins has done to bring this to us. So we're going to turn it over to you, Lainey, and let you take us through all of the information that I know you've got in store for us.
Thanks, Lainey.
Wonderful. Thanks so much, Anne and Rick. Anne, you asked what I don't have. I definitely do not have a gigantic onion or a prize-winning turnip. But I do bring you a wonderful slate of panelists today. So as Anne and Rick said, my name is Lainey Rutko, and I am a professor at Johns Hopkins in the Bloomberg School of Public Health. And I want to begin by introducing you to today's panelists, who are all my colleagues at the Johns Hopkins Coronavirus Resource Center, which I suspect many of you know as that site with the map, or just coronavirus.jhu.edu. Today, we'll be hearing from Beth Blauer. Beth is the executive director and co-founder of the Centers for Civic Impact at Johns Hopkins University. We'll also hear from Jennifer Nuzzo. Jennifer is a senior scholar at the Johns Hopkins Center for Health Security. And we will finally hear from Jeff Kahn. Jeff is the Andreas C. Dracopoulos Director at the Johns Hopkins Berman Institute of Bioethics. Now, before I turn things over to my colleagues, I wanted to begin by speaking a bit about the genesis of the Johns Hopkins Coronavirus Resource Center, and in-house we call it the CRC. So this all began in January of 2020, which feels like a million years ago now, but it turns out it was only 9 or so months ago, with a global map for tracking COVID infections that was created by Lauren Gardner. And Dr. Gardner is a faculty member at Johns Hopkins in the Whiting School of Engineering. And this map, which was posted to social media, took off. It was among the very first maps that were out there tracking COVID cases, which at the when Dr. Gardner posted it were largely in China. And of course, I'm sure you're familiar with what that map looks like today. Thank you, Beth, for sharing. So in early March, at the direction of Ron Daniels, who's the president of Johns Hopkins University, the Johns Hopkins Coronavirus Resource Center was launched. And by creating a bigger site around this map, we were able to develop a platform that leveraged the global map and let us add in data visualizations and expert analysis. For President Daniels, the site exemplifies part of what he sees as the responsibility of a research university to society. And that means having Johns Hopkins bring facts to bear on policymaking and decision-making and sharing knowledge for the world. And in a few moments, Beth Blower will speak with you about the underlying principles for the site and the importance of data transparency and democratization of data related to the COVID-19 pandemic. So that was March. A month later, in April, with support from the Bloomberg Philanthropies and the Stavros Niarchos Foundation, we expanded the site to include a dedicated section about COVID testing efforts. And this portion of the site is led by Dr. Jennifer Nuzzo, who you'll hear from during this session. Jennifer is going to discuss the implementation of the Johns Hopkins Testing Insights Initiative and challenges that have arisen related to COVID and testing data. We subsequently added another section to the site that concerned contact tracing, and this is where Dr. Jeff Kahn played a pivotal role in our plans for this section. Jeff is going to discuss a rapid response project about ethics and the role of such efforts in policymaking and thought leadership as part of the pandemic response. And the project that Jeff is going to speak about became the anchor of our contact tracing section on the site. So today, the site, the CRC, is a multidisciplinary endeavor that provides the public, policymakers, the media, and healthcare professionals throughout the world with continuously updated COVID-19 data and expert guidance. The site to date has received over 880 million page views, and we are absolutely thrilled to have the opportunity to speak with all of you about it today. Now, to humanize our panelists, and they didn't get a warning about this, I'm going to ask everyone before they begin to tell us about their preferred way to stay safe during this pandemic. And I will start to give them time to think. So for me, it's being in a very small bubble of 5 people, which is myself, my husband, our young son, and my parents. And with that, I'm going to turn it over to Beth. So Beth, first question to you, preferred way to stay safe in the pandemic, and then on to the data.
Yeah, well, I also am not leaving the house, much to the dismay of my children. And when I go to the grocery store, if I have to go out into public, I wear a full respirator that makes me look like I am certainly from a Hollywood movie.
Thanks, Beth. And I'll let everyone answer, Beth, and then we'll come back to you for your actual remarks. So Jennifer, favorite way to stay safe during this pandemic?
Yeah, so I think when this all started and the shutdowns began, there were these internet memes that were circulating about how Generation X was uniquely suited for the challenge of staying home. And that's where I think our antisocial nature really shines. And so I'm putting my homebody talents to use, and we really don't leave much at all. We do online grocery shopping and hang out outdoors as much as possible.
Thanks, Jennifer. And Jeff, how about you? Preferred way to stay safe these days?
You know, I'm staying home too, and in fact, my wife Orly calls me her jailer, so that gives you some sense of how strict I have become. Both of our car batteries have died. I mean, it's sort of like 4 walls and Instacart. That's us.
Thanks, everyone. Okay, Beth, why don't we start with you to hear about data and our site?
Yeah, sure. So Lainey really did an expert job laying out sort of the background. Our colleague, Dr. Lauren Gardner, really started off all the work that we were doing at Hopkins with this first map. And so what you're seeing here is the global map. When we first started tracking, it was just a few dots over China, and we watched with great hesitation and trepidation as the red dots started to approach our shores. And then we started to see the proliferation of disease here in the United States. And I immediately came to Lainey and to Lauren and said, I think we need to go deeper on this data. Lauren did an excellent job at laying out an open data philosophy. So all of the underlying map data in the international map was all open. So I had already sort of dug in and started to explore the US data. And I thought we needed to really kind of hone in on what was happening at the local level. I come from a background of using a lot of data in GIS in my regular work as I support mayors and other public policymakers on the use of data and public policy. And I thought, one of the observations we've made time and time again is people love to see data around where they live. They want it contextualized. They want to see how the virus is going to impact them, their neighbors. And so we decided to build a US map that would allow people to drill down to the most basic level where we could find this information. And so we rested at the county level and we released the US map in April and allowed for users who had been using our international map that were based in the United States or that were interested in what was happening in this country to do that drill down. And not only did we show how the data was impacting the United States at a local level, but we also wanted to pair that data with some really democratized information to contextualize the impact that the disease was having across three sort of key areas. The first one was our health system. We knew that the health system was going to be challenged. It was going to be under significant pressure, and we needed to create some baselines so people understood how Americans were accessing healthcare, what the capacity of our hospitals were, how many ICU beds we had, so that when we started to really stretch that health infrastructure, we knew what those baselines were. So we started sharing that data. The other thing that we observed very early on by examining the data was that there was such an incredible disproportionality of COVID in populations that were largely Black and Latino. And so we started to pair the data with deep demographic breakdown so that you can understand that when you saw disease prevalence in a county that was largely Black or Hispanic or Latino, you knew that you were seeing also some of the real divestment that we've made in the health infrastructure in this country writ large. And that manifested itself in this data, and it continues to manifest itself in the data. And then the third area that we were examining was just the case progression, and where we were looking at the intersection of public policy and the effects it was having on the disease itself. So if we had mask mandates, if we had opening and closing decisions in particular areas, how was that actually impacting the disease and the progression of disease at the local level? And after we experienced the ability to really sort of marshal all of this data together, we started putting together different types of visualizations to tell different stories about the data. We wanted to really highlight some of the observations that we were making as data professionals, but do it in a way that, my dad and mom look at the site to determine whether they're going out and using PPE or engaging in social activities with their peers. And so we started to create this library of data visualizations that gets to the heart of what we think are some of the most critical areas, and really try to also pair it with external and internal expertise. So Dr. Nuzzo is going to talk a little bit about the way that she's using the testing data and the way that we were able to leverage data in the context of it. The other thing that we did to really leverage the site was we call this map our name and shame map in some circles. And this was really to call attention to the fact that many states, when we first started collecting this data, were not sharing any of the disease data broken down by race and ethnicity. These maps were largely all gray when we started tracking this activity. And when we started to call attention to the fact that we were not collecting the data in a responsible way, we saw more and more states come online. We saw immediately the value of the work that we were doing in the data, and it allowed us to really call out those states that were not sharing, that were having detrimental impacts, particularly these sort of big racial disparities that we are observing, and be able to say the first step at being able to address this is to actually share the data. The last frontier of this is testing. We are still, as a country, doing a terrible job at expressing our testing data broken down by race and ethnicity. And so we have very little information around where there could potentially be testing deserts or where there could be real opportunities to expand testing that would allow us to see at a population level where we need to do better. And we know anecdotally where we do need to do that work, but it's certainly very important for us to have this data. And so that's sort of where we left off. And we have a few principles that are guiding us in our work. We have all of our data is open accessible. So for those people that want to explore our data, we have released the backend information in all of our visualizations and all of our data in a GitHub repository, which is just a way to essentially take all of our data and put it into your own spreadsheet so you can do your own analysis. We have millions of calls to that data on a regular basis. So we know that there are a lot of other resources that are relying on it. And the idea here is for, in the absence of an authoritative source, for us to step in and step up and do that work. And so this is where we've been, and this is what we've been doing. And that's just a little bit of a history around where we were and are with the data.
Thanks, Beth. Okay, Jennifer, over to you to hear about testing.
Yeah, so I got involved around the kind of March, April timeframe, and I got involved in this work really initially as a user of the global map and the CRC data. I'm someone who works on policy around epidemics and pandemics, and so having those case numbers assembled the way they were was really useful. But around that kind of March, April timeframe, to kind of take us back to what seems a million years ago, there were a few things going on. One, we were seeing an epidemic unfolding in Italy that was really quite troubling. The large numbers of hospitalizations that were occurring and the large numbers of deaths among the cases that they had being reported was quite troubling. And I know for the US, that was really a galvanizing moment in terms of thinking about our own vulnerabilities and what actions we would need to take in order to avert similar things from happening here in the US. And so just trying to dig into some of the case numbers that we were seeing, there were all sorts of questions that I started having as an epidemiologist, like trying to understand the population structure and also crucially the process by which countries were going out and trying to find cases. And that's obviously a process that involves testing for the virus. And so I got connected with the team just because I wanted to kind of understand more about what was going on, and learned very happily that they too were very much interested in testing and looking at it as sort of the next component of the CRC, which I was really thrilled about, because in March, this was the issue that everyone was following. And so we thought about how could we bring testing data to the site and what would be a meaningful way to do that, not just to track the numbers of tests being done, but also to track progress and how well of a job were we doing. At the time when we stood up the site, there were a lot of numbers floating around out there in terms of numbers of tests that were being done in the United States, as well as estimates of how many tests the United States needed to be doing. And when we looked at those numbers to say, okay, well, what should be a benchmark that we should use if we're going to start tracking testing to figure out if we're on the right path? And it was a hard thing to really settle on because initially the ranges that were out there were enormous. Sometimes people were saying we needed to be doing as a country 500,000 tests a day, and other people were saying we needed to do 30 million tests a day. And so just kind of faced with estimates that ranged that considerably, we had to really think critically about what is a meaningful way to track testing. And I think that's where we put sort of our public health caps on and epidemiology to work, and started thinking that it was probably not really so much about the numbers of tests being performed, but really the amount of testing being done tied to the level of infections that we thought were likely out there. Were we going to be casting a wide enough net to find infections through our testing efforts? And that really led us to kind of the main metric that we still use on the site, which is test positivity. This idea that, of the people who are you're testing, how many of them come back as positive? What we saw in March when we started looking at that metric was the test positivity was really high. And that's because testing was so constrained that if you were to get tested, chances are you were really sick, probably sick enough to be hospitalized. And, the healthcare providers had a pretty good chance that you had COVID. But we now know that in order to try to stop transmission, we have to cast a wider net. We have to include people with milder symptoms, and we have to potentially include people who don't have any symptoms. So that really, I think, affirmed for us test positivity as an important metric. When we sort of started talking about test positivity, it wasn't something that states initially tracked themselves. So we kind of took the first stab at doing that for states. And one of the things we looked at was whether or not states were testing enough to have a low enough positivity such that, first of all, we felt pretty sure that the case numbers they were reporting were something close to what they were likely experiencing. And also at that point, other knowledge about testing unfolded such that the World Health Organization also began talking about positivity as a metric and established that 5% was probably a fairly good benchmark to aim for, and that if you were had test positivities above that 5%, then you needed to do more testing. And so we initially started looking at states and seeing where they kind of fell with respect to that benchmark. And one thing I think we've seen over time, just like Beth mentioned in the kind of naming and shaming map, was that the act of tracking testing in states, I think, motivates action. I think we saw a lot of progress happening in states as they started seeing their test positivity numbers kind of stack next to each other. And that's something I'm quite proud about. We also, I think, have learned in tracking testing is that it's not just about, a particular percent positivity, but we have seen how these numbers have changed over time. And that's told us a few, I think, important things. One, I think we've learned from this is that how positivity changes over time can be an important bellwether of how well control efforts are going. And so we have seen positivity start to tick up in states that ultimately wind up having larger epidemics that we become quite worried about. And so we think it's an important metric to be looking at over time, not just, you've hit 5% and now you're great, but, how are you keeping that number low? And if not, why? And maybe more efforts are needed. We also, I think it was useful for us to be tracking it because at one point, you may remember during the summer when there was a real increase in cases in many states throughout the US and people were becoming quite alarmed about this. The president, tried to kind of reassure the American people by saying that the reason why we were seeing this increase in cases was because we were doing more testing than we had ever done. And we knew from our testing tracking efforts that he was right on that front. The US had been doing more testing than we had ever done. But because we were also tracking test positivity, what it told us was that we were not just finding more cases because we were testing more. If that had been the case, we would have seen the national test positivity stay stable or declining. But at that point, it was increasing. And so what that told us was that despite all the good work being done to expand testing in the US, the virus was outpacing those efforts. And the case numbers were increasing faster than the number of tests were increasing. So that I think was a really useful thing for us to find. And one more thing, and maybe Beth, you want to switch to the next slide. I can just kind of link it to our international efforts. It's been very helpful in contributing to the whole conversation around testing in the US in particular, to just kind of compare what countries are doing. And one of the things that we've learned, I think, in looking at testing in other countries is that first of all, the countries that all seem to be doing well in terms of keeping their case numbers under wraps all seem to be hitting that test positivity of below 5%. And many of the countries are actually quite well below that. But that it also, I think, reaffirmed that the numbers of tests may not be indicative of much because there are a number of countries who have done quite well that compared to the US have done many fewer total tests and many fewer tests per capita. But they have all done enough testing for the size of their epidemics to be able to keep their test positivity low. And so when you hear political leaders in particular sort of brag about the numbers of tests being done, I mean, recognize that there's a reason why we have to do that many tests, and it's because we have a lot of infections. And certainly our international tracking data, I think, reaffirm that for me.
Hey, thanks, Jennifer. And Jeff, now over to you.
Thanks, Lainey, and thank you, Beth and Jennifer. It's a pleasure to be on this panel with you. Really more credit to the two of you and Lainey than to me. Thank you for the shout out earlier, Anne, but really not much credit here. I'm tagging along. I'm going to shift gears a little bit and talk about a project, as Lainey mentioned, that again was prompted by our president, Ron Daniels, who early in the pandemic called me, actually it was one of those emails at 11:30 or midnight in the evening saying, "Are you around? Can you talk?" And I wondered whether I had done something really bad or he had a favor or what. We ended up talking that night and he said, "I think there's a need for some thought leadership around the ethics and governance issues related to what's being proposed for technology being used for contact tracing. What do you think? Launch this project. So let me first do a very quick little background about what we mean by contact tracing. And for those of you who are in public health, you'll know this already, but the quick overview is contact tracing is used as a core tool of public health by which a person who's infected with a disease such as COVID-19, a case is identified and the close contacts of that case are then attempted to be identified. You get in touch with the people who have been in contact with the person you know is infected. You ask those people to take protective measures, and then you follow up with the cases and the contacts of those cases and the people that they have been exposing and so on. So it's effectively trying to track down a web of those who have been exposed to infection. It's quite difficult to do in the context of a respiratory infection like the SARS-CoV-2 virus leading to COVID-19 illness. And there's some estimates that the number of people professionals who would train to do contact tracing to really carry this out in a significant and successful way in the US would be upwards of 300,000. That's just a giant number. Next slide, please, Beth. So early on in the outbreak, mostly starting in Europe and Asia, because remember, that's where the pandemic first started to show up, there was some discussion about bringing to bear digital solutions technology. And so that meant things like tracking phone records or seeing where people may have used their credit cards, where they might have accessed the health system in countries that had national health service. And that also included access to what people were being exposed to by using their smartphones. And as you see there in the bottom right, Apple and Google, in an unprecedented way, together launched a process by which there would be access to the smartphones that we all use for the purpose of digital contact tracing. Next slide. The reaction to that was, well, that could be a good idea, but how are we going to do that in a way that protects our privacy? If we're all being tracked by the contacts that we're being exposed to by having our cell phones tell somebody or something that we're in proximity to somebody who might be infected, how can we protect ourselves from having our privacy invaded? And it turns out that Apple and Google have created a process by which that happens, where the Bluetooth on your phone shakes hands effectively with the Bluetooth on someone else's phone. And that information is just stored on your phones. It doesn't get shared with public health or servers anywhere. And then when a positive test is reported, that information is sent out to all the phones that may have been near the one that we know now was infected, as a way of alerting people to their potential exposure. Very self-limited, but also not very useful to public health. Next slide, please. So the work that we engaged focused on this piece of a much larger intersecting set of performance aspects, or aspects of the way these digital technologies might be brought to bear on contact tracing. We focus on the ethics, values, and principles. That's because the work that I focus on is bioethics and public policy, and my colleagues and I saw this as an opportunity, as did our university president. But the ethics and values, the principles involved, interact and intersect. That's what this graphic is meant to display. So scientific understanding and public adoption and technical capabilities and performance considerations all interact and intersect with the ethics and governance. And when you say, make it perform better, you might actually tamp down on public adoption and acceptance, which will, of course, affect what usefulness it has for public health. So there's all this interaction and, in a sense, hydraulic relationship between the various aspects of this technology. Next slide, please. So we launched this project that started in April. Next slide, please. As it says here, April 19th was the outset. And you have to realize, in the context of academia, when scholars are asked to take on a project of this magnitude, lots of issues, lots of people. We had 50-some colleagues from across Hopkins and around the world participating. We would generally undertake that over a number of months, maybe even 18 months, a year and a half. We were asked to do this very rapidly, a very high priority from the president's perspective, and it became mine that we get this done in a way that would serve the public policy interest, the people who are making decisions about the implementation of this technology, and of course the public, who is very severely affected then and now by the pandemic. So we started in April, late April, where we put together the core writing group. We invited colleagues from across Hopkins to help us figure this out, got a consensus group formed. It wends its way here on the graphic. It's a much more linear process than it would appear in the way this is shown. But the point being, we started on April 19th and we finished our report on May the 19th. 1 month later, they took the manuscript of the report that we produced in the course of this project and turned it into a book. They published a book over the course of a week, literally 1 week, from an electronic Google Doc manuscript to a hard copy publication of a book. So we're very proud of the process and as well as the product. And I'm going to show you now just a few of the takeaways. Next slide. So we identified some high-level principles which we thought were important for people to understand and know. And this is all on the site that Lainey mentioned during the introduction. First, that transparency and public engagement are essential to an inclusive digital public health response. So we have to be clear about what we're doing and why we're doing it and engage the public. It seems pretty obvious to say that, but really important to lay that out as a fundamental principle, because the people who are involved, all of us, the public, are also the people who are being asked to use this technology, the public. So we need to be clear about what it means, what they will accept, be transparent, be clear. Next slide. Second, whatever the use of the technology, it must be done in a way that accomplishes the public health goals, but with the least infringement of civil liberties. So we don't want to infringe privacy. We don't want to take information that's private about people unless it's the only way to serve the public health goal. And that's a kind of core principle of ethics in the context of public health. And so what the answer to that is really hard to know, because the technology then in April and May of 2020 and still now is not really ripe. We don't really know what the right relationship is between the infringement on liberty and the public health goals that we want to accomplish with the digital technology being applied to contact tracing. Next slide. Third, the use of these digital public health technologies and the data from them must be guided by the best available evidence. Now that means effectively learning as we go. It's sort of like, beta testing when you're an early user of a new piece of software. This is before that. This is like the alpha testing phase, and trying to figure out, based on what we learned from the introduction in real time during a pandemic, what works best. So it's a learn as you go kind of principle. Next slide. Thanks. And then there needs to be meaningful and appropriate governance and accountability for the responsible use of the technologies. And that means state level and federal level participation. Next slide. We think, again, we don't really know, but we have an inkling that not all parts of our communities will have equal access to the technology required to make this work. So that's a smartphone. We know that some parts of our communities have smartphones, everybody in every household, but other parts of our communities do not. So we need a way, if this is a good thing, to make sure that the benefits of public health efforts are shared equitably. So that might mean something like really send more human-powered contact tracing to the parts of a community that don't have access to smartphones, and allow the technology to work in the places that are more technology rich. Next slide. The report that I mentioned was published just over Memorial Day weekend. That was May of 2020. The last data we have actually goes only through the end of August. So we were a whole month behind in showing this, but we don't get our data until a month after. So we're just waiting now for the September numbers. Incredible, actually, and part of it owing to the fact that 800 million page views to the Coronavirus Resource Center, the CRC, but it's unprecedented for an academic report, although we meant it to be very policy oriented, and it is, and very user friendly, but it has had 138,000 downloads between just the 2 months, June, July, August, 3 months, 134 countries across 6 continents. I think only Antarctica has not had a download of this book. It's available free, which is a part of the reason why it's been so widely downloaded, but nonetheless, it's still remarkable sort of uptake. It's available at the link you see there, or available, on Kindle or any place you get your e-books. I think that's the end of my slides. And with that, I'll turn it back to Lainey.
Wonderful. Thanks so much. And I want to thank everyone who's listening. I've been tracking your questions that have been coming in, and to ensure that we get to as many of them as possible, I'm going to shift over now to Q&A. So because we've gotten several, I'm going to do my best to batch these. So areas where I'm seeing a lot of common questions. Beth and Jennifer, I think you'll want to tag team on this. Can you talk a bit about how data comes to the site? How do we validate the data? Why do we feel good about our data as opposed to data that folks may see on any number of other sites out there?
Sure, I can start, and then Jen, I'll tag in. So the data is originally started in a very manual process where we were looking at publicly available data that was coming from source countries or municipalities, depending on the geographic location of where the data was available. And we were essentially building out a series of scrapers that were reaching out like tentacles and pulling in the data and bringing them into the data resources. And then we partnered with an organization on campus that has a lot more experience in building like concrete data infrastructure. And we started creating validation capacity. So all of the data that we're pulling from all of the different sources, so any source that's expressing, and these are authoritative sources only. So we're looking at sources that are coming from governments, from public health organizations, anything that's coming out or being published around the COVID-19 is coming into our environment. And then we're going through a thorough data validation process. And we're really understanding what that data is. And then we're expressing that data into the public resources. And in that expression, we're also pairing it with documentation. So if you go onto the site, you can see the map and you can see the coverage of the map and where all of the information is about the disease. But sitting beneath that is a series of articles and a series of documentation that will tell you exactly where that data is sourced, the validation process, why we are choosing certain data sources over others. It will really give you the details about the quality of that data and how that data really is aligning. So where you'll see sometimes a delta between our data and other source data, maybe because in that validation, we realize that in some places, they're including probable cases with verified cases. And so we will either back that out or decouple that for the purposes of analytics. There may be a delta because there is a source that we don't think is a trusted source that didn't sort of go through that validation process effectively. And that will also be denoted in all of the documentation. And that this whole process has allowed us to really, really understand the importance of authoritative data. We really were hoping that we were not going to be for the long game, the authoritative source, but because of the infrastructure that's been built on campus, we've been able to really continue not only to improve the pipeline of data, but that documentation that's going to be critically important now for how we're observing the disease, but also for researchers who are going to claw back into the data once we're past this acute period in the pandemic, that are going to look and see exactly the sort of opportunity that we had around this tracking. And then, Jen, I don't know if you want to talk a little bit about the testing data.
Yeah, and I think just a general overarching principle is, there's no magic to the data that we have, and they are as good as the data that are being reported by governments that are largely responsible for finding and reporting cases. And I think one of the things that we've learned in the site together is that those efforts are not always as standardized and as precise as we think they should be. And so sometimes there are issues that we see because states will suddenly stop reporting, and we need to go and figure out why. And, when we say our calculations turn up in confusing ways, we usually go back and see that, okay, well, this state has, temporarily stopped sharing data in a number of areas. So I think this is taught me in particular, kind of reinforced the importance of sort of investing in informatics and public health agencies that are ultimately responsible for finding these data. One of the things I think we've learned too is that there's just a lack of data standards. And, even though individual states or individual countries have the primary responsibility for their citizens, there is a global need to roll up these data and to understanding what's going on around the world. And so when surveillance systems are weak, or when countries are using different definitions or states are using different definitions about the data that they're sharing, it really does sort of limit our abilities to make comparisons. But those comparisons are absolutely essential. So I think, our kind of side work to all of this is not just data, but it's data to inform action. And I think some of the important actions that have been identified is our need to continue to work to improve the data environment out there.
Thanks, Beth. Thanks, Jennifer. Jennifer, no surprise, several questions about testing. So I'm gonna again try to batch them to get at the key issues that are coming up here. So can you speak about why do we care so much about testing for asymptomatic folks? Why do we not focus more on hospitalization and death?
So hospitalization and deaths are obviously really important metrics to be tracking because it tells us how, what the serious outcomes are from this virus for certain. And it also, I think, can speak to what our overall capacity to manage it is. And so we very much track those things to say, how well are we doing in order, and, do we have enough resources to be able to prevent, serious outcomes. But those are fairly late measures. And one of the reasons why we look at testing is, one, because it is the process by which we identify cases. When you report cases, there is a presumption that there is some form of test behind that case. We also look at testing because if we're not doing enough of it, that gives us a sense of how many infections we are likely missing. And the reason why we want to find infections is because ultimately what we're trying to do here is limit the spread of this virus so that we can prevent it from getting to people who can experience severe outcomes. If everybody who got it just never had symptoms, that wouldn't be the problem. But the fact is, some people do become very, very sick. They get hospitalized and they unfortunately die. We just this week passed a very grim milestone of more than 200,000 deaths. And the United States is the largest epidemic in the world. So we very much have more work to do in order to define the infections that are out there and to stop the virus from spreading between people so that we can prevent additional hospitalizations and deaths. As I mentioned earlier, when we see trends in testing go the wrong direction, usually that portends bad developments in terms of case numbers and also in terms of hospitalizations and deaths. Testing tends to be a bit of an earlier indicator that something may not be on the right path.
Thanks, Jennifer. Beth, I think this one is really for you and for me, but I'm going to suggest that you start. Can you talk about what we're doing on the site to make data more meaningful and useful to non-scientists, so to general public, to folks with no scientific training?
Well, first, we're putting it out there and trying to do it in the least convoluted way as possible. As a data scientist, I came to this work, and Lainey had to do a lot of coaching around we have to really democratize not only the way that we're visualizing the data, but also the way that we're talking about the data. And so if you look at the maps and if you look at the data visualizations that are in the Resource Center, they are very sort of basic, straightforward visualizations of that data. And what we're trying to do is tell a story of this pandemic in a way that is very easily digestible, so that as people are making decisions, whether you are a public policymaker and you're having to grapple with the tough decisions about, does my city open? Do my schools open? Do I let people dine indoors, to people like, my parents or my children who are also making individual decisions around the data, that there's a trusted source that's regularly updated, that is engaging, that also is paired with public health expertise, really trusted science, And that is, very easy to understand, but also spoken in a language that can influence decision-making at all levels. And so it's been a core value of the site. It's been something that we've worked really hard on. And so you can see really clearly that it is a very easily accessible, both in the language and also in the use of the data. And there are data tools that are really intuitive, where you just really can click through to see specific information. And we did that all very purposefully so that it was accessible to all users. And I know, Lainey, you probably have a specific position on this also.
Thanks, Beth. One of the things.
For a second, Lainey.
Oh, please, Jeff, please go ahead.
Just because you won't do this, the three of you, you heard the numbers go by 800 million, and you've heard Beth and Jen and Lainey all talk about the values behind the site. The fact that 800 million people have looked at it, or 800 million times, and that it has become a trusted, reliable source is a huge thing during this pandemic. And I know that there is huge attention being paid, not just by the policy community, the public health community, but the public. And it's a huge service that's being done at incredible level of energy and attention. And I'm not invested in it in a way that I'm talking about it in a self-serving way, except that I'm a colleague and a friend. But this is a huge amount of work, and the fact that it has become effectively the repository of record during this pandemic is a real testament to all of your work.
Thank you so much, Jeff. That's incredibly kind of you. And I'm going to use my moderator's prerogative to make that the last question, or the last comment, since we're coming up on time. But final thought. Many of you have asked questions about our team and the size of our team. So you're seeing 4 of us today, but we really are just the tip of the iceberg. We have a multidisciplinary team. And one thing that's interesting about us is that many of us have never met in person, because we only started working together during the pandemic. And 2 of our panelists today, I will not reveal which 2, actually met in person for the first time just a few weeks ago. And I believe one of them even teared up when it happened. So with that, I'm gonna thank the panel. So to Beth, to Jennifer, and to Jeff, and again, it's a real thrill to speak with all of you today. And Anne and Rick, I will pass it back to you.
Thank you very much. This was exactly the conversation that we wanted. So we really appreciate this. And I have to say, one of the joys that I have about my job at the academies is that I learn some things new every day. And to be honest with you, this was a conversation that is just like, I get to indulge what I wanted to know, because I really want to know some of this stuff. So thank you very much for this. This has been great. And Jeff, I don't know, maybe we'll give you, 3 weeks or so before we come back and say, can you please do another event and bring another amazing group of people together for us? We'll give you a little bit of a break.
Time, as you know.
Well, you all were fantastic, and we really do appreciate this. And I think that, honestly, the world appreciates all the work that you're doing. As you say, this is the tip of the iceberg, but however many there are of you, I know that you're doing a lot of good for a lot of people, and we're going to keep clicking. So please, for those of you in our audience, do keep clicking and click on the invitations that we have coming out to you, because we'll be back next week with another invitation, and it will be a partnered event with our friends at the cultural programs of the National Academy of Sciences in the series that we have been doing on creativity in the time of COVID. So COVID related, but a very different slant on things. And we'll be talking to people who write screenplays, who write books, who write plays for the stage, and to reflect on the ways in which current events are influencing the words they put on paper. And so come back next week and join us then. We'll have more rabbit holes. We'll have more good conversation. And Rick, I don't know, will you have more guitars that you're doing surgery on?
You never know when I might buy another one. So important Q&A question we didn't get to, I know didn't get answered. If you had $1 million to spend on a diamond, would you buy a diamond called Kennard?
I think that I don't know. If I had $1 million, I don't think I'd spend it on a diamond, period.
That's reasonable. Oh,
Well,
everybody, please don't forget to take our survey.
yes.
To really, we take your feedback very seriously. And by the way, we are going to try to add music next time.
Yes. So we don't confuse everybody. Is my audio working? Maybe, I don't know, Rick, I think you should be playing the guitar.
I don't know. You never know. Stranger things have happened.
Exactly. So thank you again for being here. Thank you to our whole panel because they were amazing. And we'll see you next week.
Yep. Thanks, everybody.